we're going to reference in it, but mostly this is a pragmatic talk about how do you deal with abdominal pain at LA County USC, because we have some special patients here, and I really mean that. They are special, wonderful patients, but sometimes you're like, I cannot understand what you're trying to tell me about your stomach. So we're going to talk a little bit about why this is so hard and what we can do to get better histories and better exams from our patients. Okay, so why is it so hard? This I want a lot of input too from senior residents and I guess from faculty for tips and tricks that you've come up with over the past few years. So I think one thing is that abdominal exams are tough. You have to touch a lot of stomachs to realize like what is true peritonitis, what is true tenderness. I don't like it when people touch me. I always tell my husband, go to the other side of the bed. Don't touch, you know? And so, right? Because that's like, ugh, I just want to sleep, right? So patients just don't like to be touched sometimes, right? And so there's a difference between true tenderness and even peritonitic abdomens versus someone's uncomfortable because you pushed a little too hard, right? I think another thing is the type of pain that typically comes from the abdomen. Until you get true peritonitis, most abdominal pain is visceral pain, right? And you guys remember way back in anatomy class, right? We have visceral pain and we have somatic pain. Somatic pain is I broke my arm, the ends of the bones hurt, right? Versus visceral pain, which is a different type of sensation in the body, and it's very hard to describe. Okay? Pain tolerance varies quite a bit between patients, right? I think most of you, if you've suffered through med school and then residency up to this point, your pain tolerance is pretty high, right? So, you know, that pain tolerance might be very different for different patients. You know, there's other issues of referral pain. This has to do with the visceral nature of abdominal pain, but everything's going to refer into the abdomen, and then everything in the abdomen refers out. So you have a hard time sometimes pinning down what people are trying to tell you. Okay, but I think there's two things you have to think about for abdominal pain. And the first thing, this is one of your critical jobs in emergency medicine, is identifying what's a medical issue versus what's a surgical issue. Okay? So how do we decide this? How are you going to know this ahead of time? How are you not going to find out 3 days later you admitted someone to medicine who really should have gone to the OR? Okay. So I think a lot of times this is going to come down to your history and physical. Is it sudden onset of pain? What's the quality of pain? It's getting to the right diagnosis and really paying attention to what your patients are telling you. Okay? Because you're not going to order the right tests and the right imaging if you're not listening at the beginning. And I think other reasons we think about this is that when we think about abdominal pain, we know that the intensity of workup of abdominal pain has been increasing for the past 15 to 20 years. There's more ultrasounds, there's more CT scans, there's more MRIs, but there aren't really any changes in rates of admission or mortality, right? So we're doing all these extra tests and we're not actually getting to better care. Okay, and then the other thing you have to decide in abdominal pain is who gets to stay, right? And who are you going to treat and treat, right? So these are the people that have to stay. If someone needs surgery, do they get to go home? No, they don't get to go home, right? Like they need to stay for surgery. It's not like come back tomorrow for your appendectomy, okay? If they cannot tolerate PO, if they repeatedly fail a PO challenge, you can't send that patient home, okay? That is not going to work out well for you when they come back like dehydrated and hyperkalemic the next day, right? So make sure that you're really checking for a tolerance of PO, and it can be augmented by other antiemetics, and we'll talk about that later, but people have to be able to tolerate at least fluids before you can send them out. And then those who have concerning comorbidities that might make their abdominal pain dangerous. Okay. So all those upset tummies are going to come in. What happens to them? Okay. Nationwide, 25% of patients who come in with abdominal pain end up admitted to the hospital. 21% of them, we never find out what was wrong. You could write tummy ache. The patients won't like that. Can't really put that on their discharge paperwork, but tummy ache would be a perfectly reasonable thing. And that's what, when we say abdominal pain right upper quadrant, undifferentiated, that's what we mean. We're like, their tummy hurt, and now they feel a little better, so they're going home, right? About 14 of them are actually female pelvic pain that are initially triaged as abdominal pain. Another 14% are other GU pain, right? So not uterus, but other in the GU area. And then 10% of these cases are probably going to be surgical. They need to go to the OR. And this is going to vary by hospital to hospital, obviously. This is nationwide. And what other surprises do we find? Why is abdominal pain so hard? I think the ... really tells you what's going on here. There could be anything that really refers to the abdominal pain, the abdominal area. I found this picture. It was the only non-female picture that had this little grid going on, and that's creepy. So I found a Ken doll. We're not going to go through these. This is something you just need to memorize and think about. And anytime you do your differentials, you need to have at least 5 things that could be causing the pain. So how are you going to do this? A lot of sub-Is here today. Fair amount of interns. 4s don't care. That's okay. Right. How are you going to learn to do this? Because I think there's actually a concern about RMed impacting your workup of abdominal pain patients. Has anybody been concerned about that ever? Like, how am I ever going to do this if I don't actually have someone assessing the patient first? So RMed is not new. We have had imaging and labs ordered from triage for a long time, maybe not as systematically, but this is something that happens in every hospital. So I think what you need to do as learners when you're assessing abdominal pain patients is to approach the patient as though the labs didn't really exist. Okay? Pretend that those labs and those imaging haven't been ordered yet. You're going to read the triage and the MSE note, and you need to do that on every patient. Okay? This is true for the rest of your career. There will always be surprises in the nursing triage note that you didn't address or you didn't bring up or you were rushed out of the room and didn't have a chance for the patient to talk to you about. So you need to spend 10 seconds reading through those things. You're all fast readers, right? You've all done very well in standardized testing throughout your life. You can do this, but make sure you skim through those notes or have your scribe print them out and read them aloud to you or something. Just make sure you've assessed that information. You need to check all the vital signs. Okay? Not such a big deal when your door to doctor time is 5 minutes. When your door to eventual provider time is running on 8 or 12 hours, there's a lot of vital signs in there. They're not even going to pop up on the first screen. You got to scroll all the way through, right? Because they're going to have had 3 different fevers that you missed because you weren't thorough in that. And again, when you leave this place and you have a scribe standing next to you at all time, that's their job too. And you tell them to do that on every patient. You should always see if labs were sent or imaging ordered. Don't look at what they were, but see what if it was already done, because it's kind of embarrassing when you tell the patient, oh, we're going to send some labs and we'll see this, and they're like, they already sent blood 12 times on me. So that's more of an embarrassment factor than actually going to impact your care. And then you start, as you always have, you do your history, you do your physical exam, okay? Make sure everything that's in the prior MSE and RN notes are there. Right? If the patient said they were dizzy and fell and hit their head and syncopized, and you ask the patient, they're like, no, I didn't. Then you write down, I asked the patient about the things in the RN exam, and they said, no, that didn't happen. You're going to examine your patient. You're going to treat pain, nausea, and fevers immediately as needed, not after lab testing has returned. Okay? And then think about if you need tests and what tests you need. Okay? Then you can look and see what was ordered from triage. Right? Then you can see what was already done and if there's anything you want to add to it. Okay? And I think that will help you establish how you're going to work up abdominal pain patients, because if you just look and you're like, well, they always order this, 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 and this patient, that may not be what you actually need for that patient. Okay. So there are some complicated patients, some pitfall patients we need to think about. Okay. So who avoids picking up female abdominal pain patients? That one can wait. It's only 5:30. It's an hour and a half till the next doctor's on. So there's a reason that female patients are difficult, right? There's a lot of overlapping parts, like retroperitoneal and GU and abdomen. They all kind of overlap on top of each other. You're almost always going to have to get down there, right? Unless the pain is exclusively in the right upper quadrant, right? But even then, you might have to get down there, because what if it's Fitzhugh Curtis, right? So you have to ask about it at least, and you're probably going to have to do a quick exam. Okay. Who does a bimanual exam versus a speculum exam? Who does a speculum exam on every pelvic pain patient? Okay. Notice the lack of the 4s and attendings raising hands. Right? You're like, what? It's not fair. Right? So there's no literature on this yet. There's some people that go by the theory that if they've had a speculum exam in the last year, right, that you're probably not going to find too much, right? Because what are you looking for in your speculum exam? We're going to have some people who actually selectively do speculum exams. Fourth years, what are you looking for if you're actually doing a speculum exam? Right, some masses, lesions, stuff coming out. All right, so, but I think that's true. So what he's saying is, I'm looking for a cancer, right? So if someone else has done a speculum exam on that patient in the last couple years, probably the last 6 months or so, like someone's looked at that cervix, they've said, hello, you don't have cancer, nice to meet you, right? Other things you might be looking at, stuff coming out, like I only care if it's like a river of stuff coming out. I'm going to see that without doing a speculum exam on most patients. But I think a bimanual exam is very important, right? And I'll do a bimanual exam on like pretty much anybody. I like, you don't want to do it on a lady, let me know, I'll go do it for you. Right? Because I think that those are really important things to do because you do learn a lot about what is going on, what's abdominal pain versus pelvic pain. And it's easier to do a bimanual exam than a speculum exam. If you're delaying it to get to the speculum room, just do the bimanual to start with. Okay. And I think you need to choose and order imaging wisely, right? So we have a lot of concerns about radiation, ionizing radiation in women. You're going to know if they're pregnant or not. You're going to have done an icon, but it's still something to think about. And there's a lot of other modalities. You know, pelvic ultrasound might tell you something, but it's not going to tell you everything. We have a fair number of obese patients.
Don't do it. That guy a little car. That guy a little car. Don't.
All right, so, no. I have to cut out some of the other words that happen after that. So, obese patients can be difficult to examine at times, right? The exam may be a little more difficult, right? It's going to take a little more time. You've got to be more conscious about what you're examining when you examine an obese patient. Who just gets a CT scan? It depends where I'm working. You know, depends how much time I have, to be frank. Like, this is a very careful exam that I would have to do on a patient. When I'm in East, I got all the time I want. I can hang out with the patient, we talk about their kids, then I do their abdominal exam, right? Other places that I've worked, I don't have that kind of time in examining a patient. But you do need to examine a patient for peritonitis. You might have to be a little firmer in your exam than you would be in someone who has less inches to get through. And I think something else really important is to actually check skin folds on patients. Paniculitis can be very painful and can progress to be a cellulitis and deadly. You can get zoster rashes that are hiding in skin folds and you might not appreciate. So this is a more complicated exam and you might need to recruit help occasionally. Do it politely, right? Like there's a lot of bias we have as people who tend to be very like physically active, like running around on shift and stuff. And there are a lot of things that go into obesity that aren't just physical activity and calorie balance. So be polite about it. Don't be like, hey, I need someone to come hold the skin folds. Like quietly ask a tech to come help you out. Right? Like those are things you can do to do a better physical exam on these patients. There's been a few studies. Patients with obesity don't actually require more imaging. However, the rate of obesity is increasing to such a rate it's kind of hard to tease out the confounding of those things. All right, so what are obese patients more susceptible to? They're already there. I should have done animation or something. So non-alcoholic fatty liver disease, right? That's probably related to higher levels of cholesterolemia. Gallstones, also probably related to higher levels of cholesterol. GERD, due to physical pressure. And many cancers are endocrine related. And so if you have abnormal hormones in your body, you might be more susceptible to those cancers. And the other thing is about clean catches, right? So who knows how to give patients instructions on a clean catch? Who feels like a perv when they tell someone how to do a clean catch? I kind of still do. But this is something important, right? If you're going to be sending dips and not formal micros on everyone, you need to make sure you're getting good, clean catches. So be polite, but think carefully about how you're going to tell someone to collect the urine, because your nurse probably isn't going to do that for you, right? You need to make sure that you're getting the test you want. Okay, what about the it hurts everywhere patient? These are tips I do. Who does? I don't actually turn on the ultrasound half the time. I'm just using it to like palpate the patient. Using your stethoscope, right? Asking them what they had for dinner the night before as you're examining them, those kind of things. The patients still are tender, right? But you're trying to differentiate tenderness from peritonitis. You can try treating the pain, right? Don't zonk them, but give them a little bit of pain medicine and then repeat your exam. There's been studies on this. This does not change the rate of appropriate diagnoses of surgical conditions if you give them a little pain medicine and then are able to do an exam on them. And then I think the other thing, yes?
No studies behind, but I feel like first reaction to the pain description is very exaggeratingly empathetic. It lowers the chance of kind of pan positive
Well, there is actually some literature on presentations of patients that come in with what we might consider an exaggerated pain presentation. Like one's like screaming, and then as soon as you walk out of the room, they're done. And then someone walks by and they start screaming again. So I have an interest in qualitative research. I read a lot about that, of what's going on in the emergency department, people doing qualitative studies. And there are some cultural groups in the United States that feel that if they don't present themselves in that way, they won't be taken seriously, right? And so they acknowledge that what they're doing is probably more than the pain they're having, but that's the only way to get someone to listen to them. So I think what you're saying is actually based in literature, believe it or not. And so, yes, finally. Yeah. All right, so being empathetic at the beginning can set the tone, and that can help you with establishing what you need to know and explaining that you want to treat their pain, you want to identify the source of it. There's a lot of medications you can give them, and you need to find the right one for them. And so that's why you need to do these things that they consider a little bit painful at the time.
I'd also add you should just be talking to them the whole time about something completely different. Ask where they're from, ask where they came from, or if they're giving you another complaint like vomiting, ask them about vomiting blood while you're pushing on their belly, because they're totally thinking about something different, not worried about your hand. I mean, I don't like to try and surprise them with the abdominal exam, but I don't really tell them, okay, I'm going to push on your belly now either. That's where the stethoscope, I think, also comes into play.
Right. So I think these are both really good points, and I think especially as a junior learner, like spend a little time with your seniors or your attendings when they go in and do an abdominal exam, either before or after you do, and see some of the tips and tricks that they do, because it might be different than the abdominal exam you learned like in med school, right? Like in med school is very specific, like I'm going to do this and this, or I'm going to fail the OSCE, and that might not be what's necessarily the most useful for the emergency department of identifying surgical patients and patients that might have something really bad going on. So I know you're busy, but it's really important that you learn to be good doctors, so make sure you take the time to do that. Okay, what about the non-English and in our hospital non-Spanish speaking patients and the psych patients? Okay, I think there's a lot of pitfalls that come into this. We have there's always issues with translator phones, which is how we communicate with a lot of these non-English, non-Spanish speaking patients. Are you saying pain correctly? You learned, I went to Cedars-Sinai for my internship, and I was saying sorry or something like that. It was not what I was supposed to be saying for does it hurt there? But I was like, I don't know Farsi. And they're like, no, you don't. Back off. All right, so there are these different things that you might think you've picked up, but if you're mispronouncing it, the patient's like, no, I don't want an apple. Thank you. So you got to be really careful with how you're doing these things. Make sure that you're getting good translation, right? You might be missing signs that they're in pain but don't want to tell you, particularly for psychiatric patients. They might have reasons that they're concerned about you doing further imaging or further testing, or they just want you to leave them alone, right? Especially for some of our psychiatric patients tend to be swallowers. Who's cared for some of our notorious swallowers here? Yay, right. And so, usually they will tell you, frankly, what they did, but sometimes they're embarrassed about it. Like, it wasn't something they wanted to do, they just couldn't stop themselves. And so they may not share with you everything that's been going on. So these patients may require broader testing. Right? We may be less able to rely on our history and physical exam to evaluate these patients. Okay, the elderly patient. Right? This was a series of ED elderly patients. There's a lot of things wrong with them. Right? Elderly really refers to 65 and older. Right? Let's not get too insultingly low in the age that we start calling people elderly. But there is some issues with examining elderly patients. They do have a higher pain tolerance in general than patients who are maybe 30 years younger than them. Life is hard. It just dulls the pain a little bit. But it also has to do with aging of nerves, right, and other things. So there may be a higher pain tolerance. There's also a fear of being admitted to the hospital, right? That's where people go to die. So I don't really want to get admitted to the hospital, It's not that bad. It's just a little blood. Every time I poop, that fills the toilet bowl. Just not big deal. Happens every time. So there's some concerns that elderly patients have. Additionally, as we age, our immune system tends to be less functional, and so peritonitis may develop later in the course of an infection. Right? Peritonitis is the body's response to fighting an infection that spreads throughout the abdomen. So if you have a low immune system, that is going to be more difficult to identify by physical exam. There's much higher rates of comorbidities that tend to make abdominal pain dangerous, right? Diabetes, arterial disease, peptic ulcer disease, right? All these things tend to increase as you age. And there's lower reserve. There's higher mortality for the same conditions that a younger patient might have. So you do need to be more careful in abdominal pain patients. So I remember, like, probably PGY2 year, I was like, she's 80, but she looks great. I mean, she's just a little tender in the left lower quadrant. I'm going to discharge her. And Steve Doherty was like, what are you talking about? No, you're going to scan that lady. And, of course, she had diverticulitis with an abscess because she was an old lady. She didn't want to be admitted to the hospital. Her peritonitis probably wasn't as pronounced as it would have been had she been younger. And so, that was a save, right? So I think you need to think about these patients a little more carefully. Okay? I'm less hesitant to get a CT scan on them than I would be on a younger patient for these reasons. And then also the concerns about ionizing radiation, right, are less concerning when you already have a life expectancy of 10 years. Right? It's not such a big deal if like an 85-year-old gets colon cancer compared to a 45-year-old. Okay, so what can we do for them? How do we help them feel better? Okay, so I think we've all had a little nausea and vomiting after a night like that. So there's a lot of choices for treating nausea, right? I think the big three are going to be, we're going to go with some generic names here per request of people. Ondansetron, right? And metoclopramide, right? Also known by their brand names, which I always have to look up what the generics are every time I give this talk because I'm like, I don't remember which one's which again, right? So Zofran, right, which is lovely because there's an oral dissolving tablet form in addition to the IV form, right? So that's nice for patients that don't have an IV yet or you don't have the nursing staff to give that. Compazine, which comes in oral tablet or IV form. And then Reglan, which also comes in oral, although I don't think I've ever ordered it oral in a patient in my life, and also IV form. But I think there's some other things you need to consider for specific patients. So capsaicin. Who's gotten the capsaicin talk before? Yeah, for cannabinoid hyperemesis syndrome. There's a syndrome of patients that regularly use THC that when they aren't using it, they just vomit like crazy. Right? That has to do with the changes in the receptors. They tend to be this weird thing where they take hot showers all the time, and it has to do with redirection of some of these sensations. And so if you put capsaicin on their chest, it's this essentially the same as like taking a hot shower, but it really hurts. So you guys should know this before you've done it. Like I've put this on patients, and then they've like started screaming, we're like washing their chest in the sink of the ER, and then left AMA. Which I was kind of a win, to be honest, but if misused, right, could result in a lot of complaints to your medical director. You could let them take a hot shower in the bathroom, although our shower is it even working again yet? It's back to working? It was out for a bit. We had some issues with some homeless patients needing showers desperately. But there might not be a shower facility in the emergency department you're working in, or it might be used by like a patient that actually needs decontamination. Who do we give erythromycin to? Gastroparesis patients, right? Erythromycin is a pro-motility agent, so it can work for that. And then diphenhydramine is an antihistamine, and we don't think of it as an antiemetic, but that used to be the antiemetic people had. There weren't these other options, right? And it does work to decrease nausea in a lot of patients. Who's taken Dramamine before? All the time. Every time I went up to the mountain, I would puke all over my parents, right? So that's an antihistamine, right? And that does work to prevent nausea. It doesn't just knock you out so you're not nauseated. It prevents nausea. All right, so how do you decide what to give people? There's a lot of studies that Zofran is equally as efficacious as these other medications. There's fewer side effects. So I think that's why it tends to be our first-line drug. What are the concerns about Zofran? QT prolongation. What doesn't cause QT prolongation? I'm pretty sure oxygen. Oxygen is okay? Still okay? Or is that now causing QT prolongation? So most things are going to. You need to be aware you shouldn't just give people medicines because you want to. There needs to be a reason for it, right? But that is the big concern about it. Who shouldn't get the other choices? Okay, if they actually have a history of tardive dyskinesia that you're aware of, please don't give them these medications, right? Like, that's just cruel. I have concerns generally, like a patient that I know is already very anxious or has maybe a psych background of giving these medications because it can cause an akaesthesia, where suddenly they're like, I gotta get out of here, I gotta go. And you're like, it's weird, you just got here and I just gave you some medicine, you're feeling better. Why, what's going on? And it's not that they actually have to leave, they're having the sensation that they have to keep moving, right? And they're interpreting that as like, I have to leave the ED. Tucker?
Just the other one that I add in is that just because you had that list up and SBO was prominently on there, is that any of the promotility agents, so metoclopramide, compensated also, I believe,
Right.
is that you should avoid because it can actually worsen and actually make you more prone to perforation. So
Right.
that's when, if ondansetron doesn't work, then you can actually think about using Fenner again, which is, I can't remember.
Yeah, I don't remember what Phenergan is. Does anyone remember what Phenergan is? The brand names are so easy to remember. What is it? Chlorpromazine? I think that's compazine. No, chlorpromazine. Yes, prochlorpromazine. Yes, that's true. And then, I mean, the other thing to think about, and if you know it's an SBO patient, is as much as we hate to do NG tubes in the emergency department, if you've done Zofran, it's not helping, you've given Phenergan, it's not helping, like that might actually be a patient that benefits from an NG tube, just decompression, right? Not first line for SBOs. If you do that to a patient while I'm attending you, I'm going to make that face at you. But, you know, that is something to think about that's not a medication that could help very specific patients. Right, we talked about compazine, especially for migraine patients. You know, it's did anybody see that article that came out last week? It was in Neurology. Was compazine versus Dilaudid for migraines, and compazine was slightly more effective in the short term, and long term much more effective at treating migraines. And long term being like days, not like years. So that really should be your first choice if that's available at your hospital, right? And you don't have a patient that's going to get a tardive dyskinesia on you. Yes. Ash, are you asking a question, or are you holding up the wall? Okay. The wall appreciates it. It's a very old hospital. So, and then analgesia. I don't like to start with narcotics on most of my patients unless I think they actually have peritonitis. I start with NSAIDs unless I think they have peptic ulcer disease, right? Acetaminophen, right? A GI cocktail. Who gives a GI cocktail to everybody? Okay. Our GI cocktail here is just what we traditionally give. It may be different at different hospitals, so it's something to think about when you go to a new place outside county. Narcotics are not first line, but you can still give them, right? It just shouldn't be first line for most abdominal pain patients, and you need to use logic when you mix these. Think about what you're trying to treat. Oh, that's right. I was trying to find a Dr. Jane picture, and he somehow managed to avoid the internet completely, because that was another thing. So Bentyl is a medication that's fantastic for patients who have pain that you're pretty sure isn't peritonitis. You think it's probably some kind of like gallbladder squishing down on a gallstone, or just a little dysmotility, and they're feeling like inflamed guts. I don't know if you've heard any of your patients say like my tripas are inflamada, and you're like, that doesn't make any sense, right? It's kind of this feeling of bloating, and Bentyl can be a very effective medication for that. Not appropriate if you think they have like a surgical issue though.
Going back to antiemetics, I know a lot of people have been using Haldol more for the diabetic gastroparesis in those patients. What are your thoughts on that?
I don't think that's first line. I think that's kind of more new and novel, and I think that the concern I have about Haldol generally for our hospital is that we tend to use big doses of Haldol, right? We're used to Haldol for like our hardcore alcoholic street patients, and you need to think lower dose. It's got a lot of side effects. It's going to be more likely to cause tardive dyskinesias, and I think you need to think about the other medications first. Does that answer properly? Okay.
I'm trying to comment on that. There has been a couple of papers about this recently. You know, there's one observational study that got a lot of press that seemed to show that it worked incredibly well, both in terms of opiate sparing, but more importantly for admission for these diabetic gastroparesis patients when you use this first line. And then I think either last month or the month before, in the annals, the first one I've ever seen, RCT came out.
Mm-hmm. Right.
2.5 milligrams IV, and they did find it disease for the first line treatment. So
Sure.
I don't think it's currently first line, but
I think it's,
most of the
yeah.
literature is actually moving to show that this thing has worked well anecdotally probably does have some scientific merit to it as well. And just from speaking with physicians in the community, things, it seems like they love it. For patients with known diabetic gastroparesis, like people who say that these people come in, they require like the
Yeah, no, I think it's an interesting point. I'm lagging, but that's okay, right? I can be mid-herd, not leading edge of herd.
I've been giving it for years, partly because I trained in one of the places that wrote
Right.
those papers. And we don't use it for everybody, but there are specific patients that we know who come in all the time, who had gastric emptying studies, who have these diagnoses, who we give it to all the time, and it's like magic.
So you're saying differentiated patients, not the undifferentiated eating patient.
Yeah, that's not how I use it, but in those that you know are repeat customers for the same reason.
Yeah, and I'll say it's strange because like the biochemical reasons for why it should work don't actually make much sense to me. I know it's supposed to be some kind of anti-inflammatory agent. It just seems weird. Such a low dose just works so well. I don't know if it's just the light cadence.
Right, some supratentorial.
I'm not sure, but it does seem to work in better dispos. If you don't feel comfortable using it first line, if you're on that like third shot of Dilaudid, it's probably
Cool. I have someone I'm going to give it to next time I see her in North. So other considerations, make sure you think about antibiotics. If you think a patient has a surgical etiology, you should be giving antibiotics. Don't wait for the surgeon to see them in 6 hours to give antibiotics. IV fluids for anyone who's been vomiting or has POPO intake. I think I'm out of time, and I still have a significant number of slides. Yeah, urine. Don't forget the urine. So specific things for LA County USC that I wanted to make sure we addressed. The PAN positive review of symptoms you need to be very careful about. Okay, you need to be specific about the time frame you're asking for. If you ask, do you have chest pain? They're like, I did have chest pain 6 months ago. Yeah, doctor. Right. So you need to ask like during this episode. Right. I like to ask either or multiple choice questions. So like, did you have chest pain, nausea, vomiting, and shortness of breath? If they're not actually what I'm concerned about for this particular presentation, it's my review of systems at the end. Because I think that people feel like they need to tell you yes to something, right? So like that gives them a chance to really think through what they're actually having. And try to avoid yes-no questions. If someone's answering yes to everything, right, stay away from those yes-no questions. For Spanish-speaking patients in particular, there's a lot of different words for abdomen you may have learned. Should know, like, there's some words you probably shouldn't be using in the emergency department. Like estomago and abdomen are the appropriate words for a doctor to use with an adult patient, okay? If you're talking to a little kid and you're kind of trying to make them, like, think you're funny, you can talk about their panza because it's kind of like, you know, an animal's belly a little bit. That's okay, but that's not an appropriate term for, like, an adult patient. And then vientre and barriga are terms people will know, and if maybe they don't understand estomago and abdomen, like maybe Spanish isn't their first language either, then you can maybe go to some of those slang words, but those shouldn't be the first words you use. It just sets up a disrespectful connection. You need to know the difference between sudden onset and building slowly, right? So the terms I'm not a native Spanish speaker, but the terms I found most successful are de repente and poco a poco. I don't know if anybody who maybe has more native Spanish background has other words they might use. Everyone's cool with those? Okay, because I think that that's really important when you're asking about when did the abdominal pain start, and they're like, yesterday. And you're like, did it build throughout the day? Or was it sudden onset? I had an ischemic infarct of one of my abdominal arteries, right? So those are things you really need to differentiate. And the other thing is that I think most of us have gotten through college, medical school, most of the way through residency or soon to be in residency by being very linear, goal-oriented thinkers, right? And a lot of patients don't think that way. To them, the abdominal pain they had today is the same as the abdominal pain they had a couple months ago, right? And we think differently. We think this in terms of biomedical reasons for disease, and that might be different than what your patient's trying to tell you in their story. So you need to be specific about, is it this occasion of abdominal pain, or is this something that happens every time you have abdominal pain, but maybe not this time? Ask about the clinic visits and the doctors that referred them in. Some work Erica and I did a couple years ago looked at our patients, and probably about 23 or 25% of patients had seen another doctor within 24 hours for that same condition, right? So most of your patients saw someone else, even if they're not telling you about it, right? So ask for the note. They have the note, right? Their sister might have the note in the waiting room, but someone has the note, and that's helpful information to have. And you need to find out what they've been using at home, right? There's a lot of natural remedies available. People take pretty high doses of ibuprofen sometimes to treat their GERD pain. And then also there's the phenomena of the patient that you swear has pyelo, but their urine microanalysis is negative. Who's had that situation? Okay. Of those situations, how many times has the patient just taken that one antibiotic pill that their neighbor had? Right. So this is a very common phenomenon for patients, especially with poor access to care, but for all patients. So if you think they have pyelo, they smell like pyelo, ask where they got their antibiotic from. We're not going to get through these last couple ones, I don't think. But some more stuff. Think about appendicitis, gallstones, GERD, dyspepsia, pulptic ulcer disease. Okay? Gallstone pancreatitis. Oh wait, diverticulitis first. Probably. The epidemiology is that Latino, non-Hispanic whites have higher rates of diverticulitis than age-adjusted. Gallstone pancreatitis? Yes, related to the gallstones. They tend to be younger patients, so it's the age adjustment is a little hard. Cancer, right? And cirrhosis. And we don't understand the cirrhosis yet in terms of the genetic susceptibilities that are coming with that. So take a good history, do a good exam, be judicious in your workup, be careful of elderly patients and patients with whom you have a language barrier.
And now we're going to have Erica come up and do her preview of her ASOP talk.